We have with us Dr. Aju Matthew. He's a consultant from Ernakulam Medical Center and MOSC Medical College, Kolancherry, Kerala, India.
Thank you for this opportunity. It's a great honor to be here with all of you. My name is Aju Matthew. I'm a medical oncologist. I'll be discussing an area of emerging importance, which is adjuvant CDK4/6 inhibitor in breast cancer. And the question raised to me is, do we have an answer? So as an outline, I'll present the trailer to this short film or short movie, and then I'll present a few trial data, and I'll try to torture the data as much as possible to give you an answer. So the trailer, why are we actually discussing this? Because we know that patients with hormone receptor positive breast cancer have a long-term risk of recurrence. Even with N0 disease at time point 20, nearly 29%, 20% of patients with stage 2 disease could have their cancer come back again. So it is, late recurrence is a very important area of unmet need in breast cancer. So then investigators across the world started thinking about ways to tackle this. They went back to the hallmarks of cancer, various ways carcinogenesis happens, various ways cancer grows. And we figured that there is one particular area of interest, and that is growth suppressors. Cancer grows by evading growth suppressors. Can we do something to target this axis, this hallmark of cancer? So to give you the full film, let me introduce the actors. The actors in the film are CDKs, cyclins, and retinoblastoma, RB protein. So what happens is inside your cell, you have this transition from G0, G1, S. That transition happens as the cell cycle progresses. In order for this cell cycle to progress as normally it should, you have various molecules that allows it to move that from G1 to S phase. Some of these molecules are cyclin-dependent kinases. There are multiple numbers of cyclin-dependent kinases, but our movie best actors are CDK4 and 6. Now, in breast cancer patients, there is too much of cyclin Ds, especially hormone receptor positive breast cancers. And all these cyclin Ds attach to the CDK4 and the 6, and then it causes phosphorylation of the retinoblastoma protein, which causes inhibition of the or the transcription factors, the E2F transcription factors get activated and allows the transition of the cell cycle from the G1 to S phase. So if we inhibit the cyclin-dependent kinases, especially cyclin-dependent kinase 4 and 6, the retinoblastoma protein will not get phosphorylated, and therefore the RB will play the role of a tumor suppressor as it should be. There are three major CDK4/6 inhibitors that are being used currently in India. One is palbociclib, that came first, abemaciclib, and ribociclib from three different companies. And why are we using CDK4/6 inhibitors in early breast cancer? Because we know that when you use these drugs, it causes cell cycle arrest, it causes senescence, which is a stable cell cycle arrest, and it also modulates the immune system and increases the T cell activation. And all of these, when combined with anti-estrogen therapy, helps with preventing the development of those dormant micrometastatic cells from becoming macrometastasis. So three drugs, three different types of trials. Let me take you through all these trials. First, on the left panel with the reddish or maroon kind of colors, PALACE and the Penelope B trial, which are from palbociclib. The next would be the Monarchy trial, which is for the abemaciclib, and the Natalie trial, which is for the ribociclib. Key things to remember now before I get to the detailed discussion of these trials. The PALACE trial looked at much lower risk patients compared to the Monarchy trial, which looked at a higher risk patient, and Natalie trial looked at around intermediate risk patients. So what is the PALACE trial? Now, I was fortunate to be the first investigator to recruit the first patient to this trial. So PALACE trial is used in pre- and postmenopausal women with hormone-positive breast cancer. who've completed breast surgery, chemotherapy, and have started endocrine therapy. Patients with stage 2 or 3 breast cancer. Patients are given palbociclib with endocrine therapy compared to endocrine therapy alone. Primary endpoint is invasive disease-free survival. The Penelope B trial looked at patients with higher risk disease, especially those who have residual cancer after neoadjuvant chemotherapy. Almost similar design was adopted. So compared to Pallas, Penelope had a higher risk patients, much lesser number of patients though. What happened? So for Pallas and Penelope trial, there was absolutely no benefit in preventing breast cancer recurrences or new breast cancers. So palbociclib absolutely completely failed in a lower risk setting as well as in a higher risk setting. And no subgroups, I tried to torture the data at that time to figure out whether maybe I can use it in patients with stage 3 cancer. But subgroup analysis shows that no particular subgroups of patients benefit from using adjuvant palbociclib. Now taking you through the ribociclib trial, which is called the Natalie trial. The Natalie trial looked at patients with stage 2, majority stage 2B, stage 3 cancers, hormone receptor positive, about 5,000 patients, and randomized patients to getting ribociclib plus letrozole versus standard of care letrozole and anastrozole. The end-point is invasive disease-free survival. Keep in mind that in ribociclib, patients could have stage 2 disease, but if they have no negative disease, they should have certain risk factors like grade 2 with Ki67 greater than 20%. There are some unique features of the Natalie study, and one factor is the fact that there are around 40% of patients with stage 2 N1 or stage 2 N0 higher risk who have been eligible for this trial. The second unique aspect is the dose used in the adjuvant trial is 400 milligrams as opposed to 600 milligrams daily dose in metastatic breast cancer, mainly to improve tolerability because you're trying to give this medicine to patients who are otherwise healthy or may have already been cured of the disease. So you got to ensure their tolerability. And the third part is this trial looked at an extended duration of therapy for 3 years. The Pallas trial looked at for 2 years, abemaciclib for 2 years, and here is a drug, ribociclib, looking at the data for 3 years. And the rationale for 3 years is because the mechanism of action is sort of cancer static, a cytostatic effect, we need more duration of therapy for it to actually help in inducing the senescence. So what did we find? The invasive disease-free survival, which is considered as one of the standard endpoints according to various experts and expert consensus guidelines, there was substantial invasive disease-free survival benefit with the use of ribociclib. About 3% of patients at 3 years were saved from having an invasive disease, which could be another new primary or a new ipsilateral recurrence or a metastatic disease. About 25% risk reduction for invasive disease-free survival. Now, if you don't believe the IDFS as an endpoint and you are one of those persons who believe in the distant disease recurrence-free survival as an endpoint, ribociclib at an early period itself have an absolute benefit of around 3% at 3 years, about 25% risk reduction. So again, using ribociclib does help reduce your risk of distant recurrence. Now keep in mind, I haven't said can cure your cancer yet because the overall survival is completely negative at this time point. But we know from a lot of our experience using anti-estrogen therapy that sometimes a curative benefit or a survival benefit takes longer duration. And at this point of time when the survival data, the OS data has been analyzed, only 4% of events have accrued. We need greater number of events to accrue to actually show a survival benefit. And keep in mind this is a secondary endpoint. And the benefit of ribociclib is regardless of the various predefined endpoints. Safety profile is generally considered reasonably safe, but keep in mind there is this thing called QT prolongation. About 5% of patients could have QT prolongation. 1% could have really serious, potentially critical QT prolongation. So you got to keep a close watch on that side effect. Neutropenia is there, but febrile neutropenia is negligible. What happened with reducing the dose of ribociclib from 600 to 400? Substantial drop in the rates of neutropenia and substantial drop in the rates of dangerous QT prolongation. So like the investigators assumed, reducing the dose to 400 milligrams seems like a good option, especially in an adjuvant setting. It improves the tolerability, and as far as a physician is controlled, our own risk perception of what can happen to the patient or what cannot happen to the patient. The last trial that I'll talk about today before I begin to torture the data is abemaciclib or monarchy trial. The monarchy trial is unique in such a way that it recruited the higher risk patients. Always when investigators design trials and pharma companies sit with the investigators, they have to decide and figure out, should we go for the broader possible patients to recruit and get a large market, or should we target narrow patients and ensure that the trial becomes positive? And we know from experience in lung cancer that nivolumab failed in some instance where pembro succeeded. Pembro is now a blockbuster drug, primarily because their bet was correct. So abemaciclib, this company actually looked at a higher risk patients. They wanted this drug to be absolutely positive, this trial to be positive. So the higher risk was defined by, unlike Natalie trial, stage 2, 3 cancers with node positivity. Mainly if tumor size is greater than 5 centimeter or grade is 3, 1 to 3 positive lymph nodes, but anybody with greater than 4 positive lymph nodes included. When you compare with Natalie trial, keep in mind, recruited patients with stage 2 disease, even if they have node negative status. So this is clearly a high risk population. So what happened? Invasive disease-free survival, there is clear substantial benefit even in absolute rates, about 8% absolute improvement in invasive disease-free survival benefit, about 1/3, 33% risk reduction in invasive disease-free survival. In coming to distant recurrence-free survival, again, about 7% at 5-year mark is substantial in my opinion, about 33% hazard ratio risk reduction. Again, I didn't say a survival benefit, I didn't say abemaciclib in an adjuvant setting cures patient yet, but distant recurrence-free survival is good, and the benefit is consistent across all subgroups. If you look at first recurrence, some may say it is mainly preventing a new primary, but there are substantial number of distant recurrences being prevented with the use of adjuvant abemaciclib for 2 years. But again, we are yet to convincingly say that adjuvant therapy of abemaciclib or ribociclib helps cure patients. Are we just delaying recurrences, or are we really genuinely curing patients? That can only be convincingly told if the survival data is positive. But keep in mind, again, I'm returning to my argument that says, anti-estrogen therapy takes long time to show a survival benefit. With so many excellent drugs available, with the kind of cancer we're dealing with, it takes years for a survival benefit to be manifesting itself. Safety is very important, especially when we're using it in an adjuvant setting. What are the concerns? Diarrhea. A lot of patients end up with diarrhea, but appropriate use of Imodium, loperamide, and dose reduction, most patients are able to handle the drug fairly well. But rare risk, but can happen if you don't think about it, is venous thromboembolism. Abemaciclib has about 2% or 1% risk of causing venous thromboembolism. So if you have a patient who is on abemaciclib for whatever indication you're using, patient comes with chest pain or discomfort, keep in mind this is possible. And otherwise it's a fairly okay drug. Risk of febrile neutropenia is marginal. So now coming back to the last part of my talk, torturing the data, do we have an answer? This is a specific question Dr. Vamshi wanted me to answer. Should we use this in stage 2, 3 cancer? And the second question I must answer before I finish is, which of the 3 drugs must we choose if we believe we must use a drug? So coming back to that first question, should we use it in stage 2 or 3 cancer? And that question, the seminal question in this is adjuvant CDK4/6 inhibitor really curing cancer? Why is there no overall survival benefit? Now, the counter argument, the counterfactual is, it doesn't cure patients. It is just delaying the inevitable. The distant recurrences are being delayed. There is no curative role. And one of the reason this could be stated that it is not real is because some of these trials are large, 5,000 patient studies. So when you have large trials, you're trying to torture the data using third-degree methods and trying to harness those small, tiny marginal benefit with a p-value of 0.00, whatever we want to find. But the absolute benefit may be small and slim. But the reality is, in today's world, some of these adjuvant trials, especially in breast cancer, have to be large, and it has to be powered appropriately and accordingly so that we actually can gain an answer to the question that we have to get. So I think all these 3 trials are reasonably well powered, reasonably well designed to obtain the answer to the question that we seek to answer, and therefore a more narrower, a more higher risk patients, should we have done a trial using that? I don't think so, because we really need to find a benefit for the broader segment of patients, because late recurrences are common. 20% risk of recurrence at year 20, even for node-negative stage 2 cancer, as I discussed in my first slide. The other counterfactual argument is, why are we talking about IDFS as a primary endpoint? Should we have overall survival? Now here's where experts have come together. They may have conflicts of interest, whatever, but at least they've published it, they've given it for arguments, all of us had the opportunity to counter it, and they've all come up with a steep guideline. They said IDFS is a good endpoint for breast cancer adjuvant trials. And again, these trials are looking at IDFS, but are not forgetting about the survival data as well. But I believe IDFS may be a decent surrogate in breast cancer, as most experts in that consensus guidelines have agreed as well. But we will watch out for the overall survival. But the problem with breast cancer in an adjuvant setting, it takes years for survival benefit to be manifested. So should we withhold therapy, which is potentially active therapy, for that patient who comes to you with node N2 disease, stage 3, and wait and say that it delays recurrences, I know, but I don't really know if it cures you. So I just want to wait until overall survival data is available. By then the patient may actually die. So I believe this is not a very good argument that the endpoint in such trials should be survival itself. The third and the last point is open label study design. This is subjected to bias, but for breast cancer studies, especially if the investigators have done HRQOL studies, quality of life studies, there haven't been much difference in the quality of life data between the 2 drugs. Censoring is a concern, but early events suggest accruing. As time goes by, we will know greater detail in how much censoring can cause spuriously significant results for this sort of trial. But I think as early data is coming in, trickling in, as cephalologists, election predictions comes, I think we have early data. We can convincingly say that adjuvant CDK4/6 inhibitors does cure high-risk breast cancer. Now coming to the second part, which drug? Why differential effect? If you look at palbociclib, abemaciclib, and ribociclib, palbociclib has never been shown to cause any survival benefit. And one of the reasons is palbociclib inhibits CDK6 in greater magnitude than CDK4. CDK6 is expressed in higher proportion in your bone marrows. So when you give drug palbociclib, the bone marrow progenitor cells are inhibited at a greater threshold, at a greater way. Therefore, the tolerability of the drug drops. You are unable to dose it appropriately, and it is not a great CDK4 inhibitor itself. So that could be one reason palbociclib is not giving us a survival benefit. Although I must also say there are some trial design issues, like a large number of patients who have stage 2 cancer recruited to the PALACE trial. So let me summarize. Hormone receptor positive breast cancer, even early stage cancers, have a long late recurrence risk. CDK4/6 inhibitors are active in breast cancer, unequivocally in metastatic disease, but early signs suggest that these are active drugs in early stage setting as well. Adjuvant abemaciclib and ribociclib helps improve validated endpoints. Overall survival benefits are yet to be found, but I believe as time goes by, we will see it, because substantial distant recurrence-free survival benefit has been shown, especially in high-risk cohort. Palbociclib has failed to show any benefit in this patient population. So that is it, and I'm happy to answer any questions if you have.